Live. It's Dr. Twyman, helping you guys become heart attack proof since at least 2019 when I opened my practice, Apollo Cardiology in St. Louis. Tonight we have another great Ask Me Anything. Every Monday morning I put in my stories a box where you can submit your questions. I answer them as long as it's not too direct, specific, one-on-one medical advice. More that's kind of general educational purposes to help you understand how you can reduce your risk of having cardiovascular events and either work with myself in the office if you work with me or with your local doctors. So we have a couple housekeeping things tonight. One, I do have a Skool community. There's going to be a coffee and cardiology version of Ask Me Anything tomorrow at 8 a.m. Central Time. I messed up the calendar. It was supposed to be this morning, but it's going to be tomorrow at 8 a.m. for those that are in my Skool community. If you're interested, what do we do there? Well, we do more in-depth, IG Live type of Ask Me Anythings. People can share their labs if they desire. I'm sharing some insights on previous conferences I went to. I was recently at the Mayo Clinic conference about AI and cardiology. I shared a summary of the 3 days of my experiences at the conference. So anything that I'm learning, I'm sharing in the Skool community, and people are free to ask me questions there. So that's the most place that if you want to ask me something that you're not my patient, that's the best way to find me. So there is a free 7-day trial for Skool. Check it out if you like. 8 a.m. tomorrow, Central Time, doing an hour-long Ask Me Anything. So that is housekeeping tip number 1. Number 2, I'm doing the Canyon Ranch retreat later this week. For those that are attending, I did send out an email last night and also a update of the itinerary in the Telegram group. So if you're watching this and I have not met you before and you're attending this event, please check your email. Please sign up for the Telegram group because that's what we're going to utilize to stay connected when we're in Tucson doing all the biohacking and talking about mitochondrial optimization and going through all the health span longevity topics you guys want to chat about. So with the housekeeping out of the way, we'll jump into the questions tonight. So question number 1, do varicose veins have any relationship to CVD, cardiovascular disease? So by definition, they are cardiovascular disease because they are a vascular problem. But are you asking, is it a risk factor for coronary artery disease or risk of heart attack or stroke? No, it is not. Most varicose veins are cosmetic in nature. Some people have pain from the swelling that occurs. Some people develop blood clots and may need therapies, medications or treatments for the varicose veins, but just having varicose veins does not increase your risk of coronary artery disease, but they are cardiovascular disease because the veins are a vascular structure. Next question, where did the 120 blood pressure numbers come from? I assume this means from the guidelines. So, the systolic pressure is the top number, the diastolic pressure is the lower number. Multiple trials show that the lower the better, less cardiovascular events, less MACE, major adverse cardiovascular endpoints, so less strokes, heart attacks, dementia, kidney failure, the lower your blood pressure. So most the data is now coming from the SPRINT trial that irrespective of age, 120 radius is the cut point you really want to try to maintain, ideally through lifestyle, fix any nutrient or supplement deficiencies, and use medications when needed, particularly if the blood pressure is persistently greater than 140/90. There are studies, or I should say more probably epidemiologically related observational studies, that the risk really starts increasing when it's greater than 115/75. But there are no guidelines to my knowledge that recommend using medications to get people down to that range. For each point that you're greater than 115, so example, your blood pressure is 135/80. Subtract 115 from the 135, that is 20. You have a 20% relative increased risk of a stroke compared to somebody whose blood pressure is 115. Next question up tonight, does plaque get deposited evenly or does it have favorite places to accumulate? Great question. I often use the fun fact that you have nearly 60,000 miles of blood vessels. That's why you have to go looking from head to toe to assess where the person has plaque because it doesn't get evenly distributed in all territories. It tends to develop in areas where high shear stress, so areas where there's multiple side branches of arteries. think of a river with a bifurcation point. Wherever there's a bifurcation point, there is more shear stress. That's where plaque tends to form, is wherever arteries have a kind of side branch coming off of it. So test, don't guess, head to toe, carotid intimal medial thickness scans, calcium scores, CT angiograms, particularly with clearly analysis, abdominal aortic aneurysm assessments, ankle brachial index. Those are good starting points to look for vascular disease. Next question. How effective is spirulina on lowering blood pressure? I've not seen any data that spirulina does anything significant for lowering blood pressure. I have some patients taking it more for detoxification. So can support it for maybe detox if you have a desire to do it for that, but I've not seen any great data that it significantly lowers blood pressure. Often blood pressure is elevated due to nitric oxide being low, or the person has significant oxidative stress or inflammation, so go fixing the root causes of those. How concerning are the studies about xylitol and heart health? To my knowledge, that is not that significant. Most people aren't going to be able to consume the volume of xylitol that would be necessary to be a problem. I believe Dr. Peter Attia, he has a podcast, The Drive, where he's gone through like an hour or two long podcast all about this topic. So not something that I personally stress about. I don't go looking for products that are xylitol free, but I'm not trying to consume great quantities of it either. Next question, can red yeast rice help lower LDL-P? Yes. Red yeast rice is an HMG co-reductase inhibitor. It is working on the same pathways that statins work on. It is just generally not as potent or as strong at lowering LDL particles as statins. All right, this is going to be more context, but do I think sestimibute rest and stress is safe on your heart if you can't do a treadmill? So the first question is always going to be, what is the stress test being ordered for? If a stress test is being ordered because you have symptoms, chest pain, pressure, shortness of breath, exercise intolerance, abnormal EKG, abnormal echocardiogram that shows the heart is weak and you're looking for ischemia, then yes, it is reasonable. If somebody's doing a stress test and has no symptoms, you have to really ask why. What are you going to do with that information? The best type of stress test is exercise, because you want to see, can you recreate the symptoms that the person had during stress? So if somebody cannot walk on a treadmill, if it's due to an orthopedic limitation, that's one thing, but it's because they're so deconditioned, or they have crushing chest pain the second they start walking across the room, that is a bad sign. So if you have to do a chemical stress test, there is dobutamine to increase the heart rate and the heart contractility. There is using the LexiScan, which is going to be utilized as the vasodilator for a sestimibute scan. So the nuclear stress tests are more sensitive than a plain stress test with treadmill only, but it does come with the risk of that it requires medical radiation at a higher dose than a cardiac catheterization or CT coronary angiogram. So it is safe if there's a good indication and you're going to make an intervention based off the results of the stress test. If it's being done just for, quote, screening, the risk probably outweighs the benefit in that instance. All right. Next question up tonight. What non-invasive tests do I recommend to diagnose microvascular coronary dysfunction? So this is equivalent to endothelial dysfunction. So in my office, I do pulse wave velocity testing with the max pulse. Tells us if your arteries are stiff or elastic. I do the endopat scan, which looks at reactive hyperemia. So you put a blood pressure cuff on somebody's arm. You have probes on each fingertip looking at the flow in the fingertips. You pump up a blood pressure cuff higher than your systolic pressure. the flow is temporarily cut to the one finger, so it goes flatline. The other arm acts as the control. After 5 minutes, you release the stopcock. Blood rushes back down into the arm, causing reactive hyperemia. Code word, increased blood flow into the arm. The increased blood flow stimulates the glycocalyx, which is the lining of the artery. If the artery is healthy, nitric oxide is released, the arteries dilate. The artery should triple or quadruple in size. That is optimal. If the score on the test is less than 1.68, you have endothelial dysfunction, and you likely would have microvascular coronary dysfunction as well. That is the most common way that I would measure it non-invasively. You can look at biomarkers, including homocysteine, ADMA, uric acid, urine microalbumin creatinine. If they're abnormal, you may have endothelial dysfunction. But to truly diagnose it, it's generally going to be more invasive doing acetylcholine challenge testing. So it really depends on what the symptoms are. Sometimes you can do it non-invasively, but if symptoms are bad enough, you got to rule out that there's obstructive coronary disease as well. All right. So those are the pre-submitted questions. Thank you guys as always. Next Monday, 6 p.m. We'll do it again. And you can put your questions in the question box in my stories starting Monday mornings. For those that are joining, I am having a coffee and cardiology tomorrow in my school community at 8 a.m. I messed up the calendar link today. It's supposed to be today. But there's questions already pre-submitted in that group as well. But we can go into further back and forth in that group. People can log on. I can see them. They can share more details. They can share labs if they desire or imaging. And we can go for up to an hour tomorrow. But that's where I share a lot more of my educational materials. I was recently at the AI conference in California. I actually did have a demo today of the AI EKG technology. I will be bringing that to Apollo Cardiology the second I get the spec sheets from the company. Do have to acquire a new piece of gear to be able to make it work with my EKG systems, but I'll in short order be able to tell you essentially how old you are from your EKG, and also what is the likelihood your heart function is normal, or do you have a cardiomyopathy, a weak heart pump where your ejection fraction is less than 40%. It's going to be pretty slick. Eventually, there's going to be algorithms which can also tell you your risk of atrial fibrillation, pulmonary hypertension, amyloidosis, even liver disease. Those will probably be rolled out sometime next year. No guarantees, but waiting on FDA clearance for the other algorithms. So going to be always trying to get to the tip of the spear for cardiovascular testing at Apollo Cardiology. So the AI EKG software is coming soon. All right. And then I'm reviewing the comments here. So somebody did put a question in here. Would I recommend a statin for an LDL of 112, HDL of 97, triglycerides of 53, and ApoB of 90? Somebody said they've read an ApoB should be less than 60. So in that traditional lipid panel, unknown if an LDL of 112 is a problem. It's much more predictive to look at the LDL particles or an ApoB. Particles predict the risk. So an ApoB of 90 would probably put you near the 50th percentile. 50% of the world would have values higher than you, 50% lower. If you have coronary atherosclerosis, you've had plaque in your carotid arteries, you've had a cardiac event, then yes, probably shooting for an ApoB of 60 is more reasonable, using whatever tool. Statins are one of those tools for people to utilize. But if you can't tolerate statins or for whatever reason prefer not to take them, you can use PCSK9 inhibitors, ezetimibe, or Xylitol. They all have outcome data as well. As for the triglycerides of 53, that's generally a good sign that the person's not going to be pre-diabetic or diabetic. But I would be concerned about the HDL of 97, particularly in a woman. It's often a sign of dysfunctional HDL. High inflammation can drive HDL higher. HDL is not, quote, good cholesterol, but high HDL is often a marker of vascular inflammation. So test, don't guess, look for it. Saw patients today doing telemedicine who had reverse cholesterol transport issues. They had very dysfunctional HDL. So focus on the ApoB first, but may need to do further testing to assess is the HDL a problem or not. All right, so I think all the questions have been answered for this evening. I will put this replay up in my Instagram feed for the next 24 hours, and then it goes into the archives. But I will put it into my to-do list to download it, re-upload it to my Instagram channel, which is drtwyman.tv. And that's where the AI transcribes it, so you can do a little bit of searching to figure out answer to a question that you may have not heard me answer in the past. Not all the archives have these, but I'm trying to going forward. If you're interested in more education, if you're interested in more, learning about how your vascular system works, consider joining the Skool community. There's a free 7-day trial to check it out, see if it works for you. See the like-minded people that are in the group. There's courses in there, how to read your own labs, how to become heart attack proof, and I'm doing longer form Ask Me Anythings there. The next one is tomorrow, 8 a.m. Central Time. So hope you guys have a great evening. I'll drop the link to my Skool community in my stories in a moment, and I'll see you next Monday.